We are now going to have creating accessible and inclusive clinical settings with Melissa Cheplic. I'm pleased now to introduce Melissa. She's returning. This is her second year with us with our Inclusive Mental Health Symposium, and I'm so glad to have her back. Melissa has also done training for our staff at Nutley Family Service Bureau prior to participating in our first annual Inclusive Mental Health Symposium. So welcome, Melissa. She's a senior training and consultation specialist at the Boggs Center on Disability and Human Development at Rutgers Medical School. Melissa designs and delivers training to community providers, state agencies, health professionals, and university students. She holds a master's degree in public health, is a NADD certified clinician in dual diagnosis, and is currently a doctor of public health candidate at Rutgers. Melissa has also created nationally recognized curricula on behavior and mental health, and she co-authored the manual Mental Health Approaches to IDD. Please welcome Melissa Cheplic.
Hi, thank you. Thank you so much, Catherine, for having me back. Thank you to all our friends and colleagues at Nutley Family Services for making this wonderful event. Congratulations to everyone, and thank you so much for making time to be here for this session and to listen a little bit to me for the next little bit together. So welcome and thank you, and again, congratulations on a wonderful symposium. So as Catherine said, I am a trainer with the Boggs Center on Disability and Human Development. I provide a lot of community training to our provider partners throughout the state. And also in my role at the university, I have an opportunity to teach and to develop the capacity of our future professionals in allied health and social work and medicine and public health in being more inclusive for the needs of people with disabilities across the lifespan and across settings. So I wanted to welcome you in to talk this afternoon about real accessible, inclusive settings, clinical settings where people with disabilities seek out healthcare and other clinical settings. So our focus on mental health is helpful as we start to consider the needs of people in our community and in particular settings where people seek to get their needs met. So our research from NAMI tells us that 1 in 4 Americans have a diagnosable mental health disorder, and that minority populations are less likely to receive diagnosis and have less access to behavioral health services. When we think about disability and people that we support with intellectual and developmental disabilities and autism and other types of disability experiences, they're represented here in these minority populations receiving diagnoses on delay, having access barriers to mental health services. And so we see that across the lifespan. When we look at our data from CDC, this is our behavioral risk factor surveillance survey data. And our BRIFIS data tells us that people who have disabilities, adults with disabilities, are more likely to report frequent mental distress 5 times as often as their counterparts who do not have disabilities. So 5 times as often people are experiencing mental health concerns across the lifespan. And specifically for the population of people with intellectual and developmental disabilities, about 55% of people will have that co-occurring mental health condition over the course of their lifetime. So just to give us a sense of where the needs are, we're likely in the course of our work, whether we're working with young people in schools, whether we're helping people get jobs or helping them with their relationships, whether we work in adult service systems as providers or we're seeing people in the community to meet other healthcare needs, we're likely to encounter and support people who have mental health needs that co-occur with their disability. And it's helpful for us to kind of recognize the risk factors of why people with disabilities are more likely to experience secondary mental health challenges and have just poor mental health outcomes over the course of their lifetime compared to their counterparts who do not have disabilities. And some of that comes from the disability experience itself. We know that people who experience disabilities are more likely to have secondary health issues. People with disabilities are more likely to experience unemployment and underemployment and food insecurity, troubles accessing transportation. There's higher rates of racism and segregation and trauma and isolation in our disability population. We see people encounter challenges with communication and language, transportation and housing. All of these protective factors that help us have good mental health outcomes are either less accessible or inaccessible to people by virtue of those disability experiences. And we also see people operate and live and work in systems and structures that are not accessible, that are not inclusive. It's very hard to get your needs met in environments, in communities that are not set up to meet your needs. And unfortunately, this is the reality. This is the experience of people with disabilities across different settings. So we look at this through our larger lens of understanding disability as being both a social determinant of health and also as an indicator of our ability to access these other things that determine health outcomes. So when we look at health in general, and we identify all of those factors that lead to health outcomes, it's inclusive of these things we see here, like education and employment and economic stability and the neighborhoods where we live. If our neighborhoods and housing is affordable and inclusive and accessible for all the people in that community, right? Access means everywhere. Inclusion means everyone. And we know very well that there are other barriers and risk factors that prevent people from getting their needs met in the community. And that has a detrimental effect on their physical health and, of course, in their mental health, particularly when we see higher rates of mental health for people who have disability experiences. One of the challenges that we have is that we can't see symptoms, right? We cannot see symptoms. We see signs, we see indicators. People often tell us and show us that their needs are changing when their behavior is changing. And there's so many different reasons that we see behavior change. Behavior changes because we have unmet needs. Behavior changes because of our health. Behavior changes because of the environment and grief and loss and transition. And relationships end and programs change and staff turnover and seasons change and the temperature changes. So one of the challenges that we have as we strive to support people is that sometimes it's difficult for us to understand what behavior change is telling us. So it's helpful to have some guidelines that point to mental health as being the reason. So there's some specific indicators of a mental health condition that would indicate to us that people's behavior is changing because they have those unmet mental health needs. So any rapid onset increase or change in behavior and symptoms, those kinds of acute changes that we see, we contrast that with physical health changes, things like an ulcer, things like arthritis, carpal tunnel syndrome, other non-injury physical changes can be more insidious. We see those changes happen over time, but a rapid onset or increase in symptoms or behaviors likely indicates a mental health condition. When we see changes in sleep or eating or affect or mood that cannot be attributed to another reason, that could potentially be a mental health condition. So sometimes people are working to change their sleep or eating or their diet, but if we're seeing those changes in the absence of another reason, that could be a mental health condition. We also look for things like decline in hygiene, purposeful self-harm, hallucinations, substance abuse. These are challenges that can typically occur with a behavior change, with a mental health condition as an underlying cause. And then a very helpful piece in providing services and understanding needs is that we're likely to see mental health symptoms across environments, across settings. If we're seeing behavior change at home but not school, at work but not home, inside but not outside, in the morning but not at night, if we can sort of isolate those barriers and those variables in the environment, we can understand those typical environmental reasons that behavior changes. But if we're seeing behavior across symptoms, across settings, it really does indicate to us the possibility of a mental health condition. So within our access systems, right, it's very hard sometimes for people with disabilities to access healthcare, to access mental health supports. And these disparities are the reason that we see poor health outcomes for people with disabilities. When we talk about a disparity is a preventable difference. A disparity means that there's no medical or biological reason that we should see this difference in outcomes. And yet, we do see this difference in outcomes for people with disabilities precisely because these preventable differences occur. 1 in 4 adults with disabilities do not have a usual healthcare provider. 1 in 5 have an unmet healthcare need because of cost in the past year. 1 in 4 do not have a routine checkup in the past year. And this is just a cross section of a larger data set that I included here to start to look at access to healthcare among people with disabilities, and also to highlight that because we look at disability through a medical model, we tend to be insufficient when it comes to health promotion, health prevention, those things that we can do to support wellness and primary care and routine things that help us feel healthy are often inaccessible or harder to reach for people who do have disability experiences. When we look quite specifically at healthcare access, we see challenges and barriers that exist from the biggest macro systemic challenges to the most individual interpersonal challenges through our interactions and our environments. And what I hope to do today is to start to think of some useful practical ways that we can improve settings to ensure access, both in those big ways and in those interactions that we have with people in clinical settings. So, a big systems challenge that we continue to have, and I know that many of us have these experiences, that we often see services and supports delivered in fragmented systems. So, between adult and child systems, between school, education, and adult services, but also even within healthcare itself. Often people with disabilities see many providers, they take many medications, they get their care and support from different sources, and having the funds and the expertise and the systems to manage that coordination can sometimes be difficult. Communication is a huge issue. Many people who have the experience of disability may not have traditional language. They may not use language or verbal skills to communicate. And that can be very hard to tell people what you need or to communicate to others that you are feeling particular symptoms. When we think about mental health specifically, a lot of the tools that we use to diagnose and treat mental health and mental health conditions rely on self-report. So if people don't have language, if English is not their primary language, if people are not able to express or remember or have the insight to report these things, a lot of that information doesn't get to people who can help them. And one of the best practice ways to ensure accessibility is to add more time. But We can add more time sometimes, right? It's very hard to add time. Sometimes our funding structure or our schedule structure only allows for a certain amount of time, which can be difficult for people to meet everyone's needs within those time frames. And people have medical trauma, going to the doctor, having invasive procedures, not being able to deliver consent about them is unfortunately typical of disability experience. Having a lot of encounters with different providers and strangers can cause medical trauma. We also see challenges across our provider knowledge, right? We know that sometimes it's hard to find a doctor, to find a counselor, to find a clinician, to find a provider who's going to understand and honor and recognize the needs of people with disabilities. And so there's a gap sometimes in provider knowledge that can also stand in the way to people getting their needs met when they go into settings for healthcare and support. And of course, those bigger social determinant issues like insurance and funding and employment and transportation and Medicaid issues. And when people make it to the setting, often the setting itself is not accessible. The exam rooms, exam tables, offices may not be big enough for wheelchair access or to accommodate other adaptive equipment. People who are sensitive to light and sound and crowds and noises and other people may have to contend with some of these sensory issues and overstimulation in offices and areas that they can't control. There's a lot of information that's exchanged along the process from checking in to receiving prescriptions to discharge information, follow-up information, following digital information in my chart or other e-records or i-records might be difficult for people to follow who don't use a smartphone, who can't have access to Wi-Fi, who have multiple people who are following up on their information, making sure everyone sees it. We kind of come back around to coordination of care. And just the fact that most systems and most offices are not necessarily set up, whether it be with restrooms, with language accommodations, with parking, to just help people have a more accessible physical and social environment, to get their needs met. So we see these challenges in big ways, and we see these challenges in small ways. And then this can also present when people come for care. Oftentimes, when people are seeking mental health treatment and they're looking for counseling or assessment or diagnosis of their conditions and their symptoms, there's also some interpersonal or interaction barriers that can occur that can either interfere with or delay getting an appropriate, accurate mental health diagnosis. It has been and it remains very difficult for people with disabilities, particularly intellectual, developmental disabilities, autism, other cognitive challenges, to get a timely, accurate mental health condition diagnosed properly. A lot of that is communication. As I mentioned, self-report, being able to identify symptoms is very difficult for people. A lot of the tools we use, the DSM and other questionnaires, also rely on self-report, confirmation, verification of symptoms, which is hard for people. We also see diagnostic overshadowing. This is what occurs when we know that people have a disability and we attribute all of those other changes in behavior to the disability itself. We see this in mental health and we see this in physical health, right? People with disabilities may have a toothache, they may have a bowel obstruction, they may have a UTI or kidney stones or migraine headaches. And if they can't express that and they don't use language, they're going to communicate that through behavior. And just think about what a kidney stone looks like on day 3 of not being able to say so, or managing a migraine headache in an environment that is overstimulating with high levels of sound and noise and crowd. And so we think some of these behaviors are typical of a disability or they're typical of autism, when in reality, people are experiencing pain or discomfort or symptoms that are associated with another problem. And of course, we see that in mental health as well, right? Dealing with anxiety, having mood changes, working through trauma. People with disabilities have those experiences. And with diagnostic overshadowing, we sort of think, well, this is typical. This is what disability looks like. This is what autism looks like. And we miss these indicators and signs of additional problems. We also have atypical and episodic presentation. In other words, things might not look how we think they're going to look. We may have an idea of depression as being low energy, and depression means that people are withdrawn and that people are quiet, but maybe it looks like aggression. Maybe it looks like confusion. Maybe it looks like indecision. And we tend to look at things through a behavioral lens, and we're seeing those behaviors as noncompliance or task avoidance or agitation, when in reality, it may be signs of a mental health condition. We also experience baseline exaggeration. Sometimes in clinical settings, we see people at their worst. People are coming to clinical settings because they're in crisis, because they're in pain, because they've been experiencing mental health symptoms, because other people are not able to support and help them. So when people come into the setting, we recognize that there are these additional episodic presentations, baseline exaggerations that take place as well. And wait times are longer, and people are unfamiliar. And we might have to wait longer than we would if we were in another environment. So these are also barriers to inclusive care, barriers to inclusive treatment as well. So what is this going to look like if you are a person providing services or care to people in these different settings? Here are some things that we can look for to indicate to us that people may need more, that people may need more accommodations, that people may need more support. Challenges with transportation and access and cost, right? Oftentimes people present in clinical settings, in crisis settings, repeatedly for the same issue, which may be related to inability to get their needs met in other places. People might have trouble accessing transportation and cost, and be able to pay for services and be able to follow up services. So if we are giving referrals to people or resources, it might be harder for them to be able to access those things as well. Language and communication. And thinking about how people tell us their needs, it might take longer for people to answer questions. It may be difficult for people to be able to fill out paperwork, answer questions about their symptoms, communicate their needs, tell us about their history. We also see high vulnerability to stress, which can happen when people experience trauma, when people are highly agitated or dysregulated in clinical settings. And then we see this in behavior, right? The need to reduce stress, to run away, to be triggered by stressors, especially in medical settings, maybe a white coat, maybe a stethoscope, maybe any badge or indicator of law enforcement, maybe a name tag, maybe bright lights. These are stressors that may indicate to people that they're uncomfortable and they don't feel safe because perhaps they do have trauma from those prior interactions. And we think about medication, right? A lot of the medications that people take, psychotropic medications, can cause things like changes in affect and mood and depression and hearing and appetite and sleep. Those are the very things that we're often looking for when we are thinking about understanding mental health symptoms. So we can see medication be able to mask or be able to mimic those signs and symptoms of a mental health condition as well. And again, the variability in provider knowledge and experience with disability needs across settings can also be a challenge that we experience in practice. I love this graphic here that is really showing us the possibility for equity and the missed opportunities that we often encounter. Here is a school that is after a snowstorm, and there's a gentleman here who's shoveling the stairs, and someone's asking, could you please shovel the ramp? And he's saying, well, all these other kids are waiting to use the stairs. When I get through shoveling them off, I'll clear the ramp for you. And the student's saying, if you shovel the ramp, we can all get in, right? If you shovel the ramp, we can all go. But this is a pretty typical experience when we think about disability accommodations and disability supports. We do the stairs first, and then if there's time, if there's money, if there's resources, then maybe we can shovel the ramp later. But if we shovel the ramp first, more people would be able to get in, right? That is universal design. That is universal framework. The more we do for everyone, the more likely we're going to be able to meet the needs of the most people, right? Being inclusive, being accessible is not necessarily being disability specific, but it's being open to finding strategies, opportunities, practices that are going to do the most for the most people. We see this in mental health, in emergency preparedness, in community planning, in public health. The more we do, right, the more we do up front for the most people, the greater the likelihood that we're going to be able to meet those most needs. So let's find a way to really shovel the ramp, right? People who use the stairs are still going to be able to use the ramp. Everyone is going to benefit from these practice improvements, from these opportunities, just to address some of these barriers to make some of these things more accessible and more inclusive. That starts with the physical space, right? We want to create more physical and socially supportive settings, but also inclusive spaces where we can adjust noise, lighting, space, textures. My colleagues and I had the opportunity to work with some hospital systems, creating sensory-friendly environments for people in emergency rooms. And some of our biggest allies and collaborators were the security guards and the non-clinical staff in those spaces, people who are in charge of waiting rooms, people who are in charge of giving interactions when information is not available, really creating space, noise, textures, waiting spaces that are just more comfortable for people in general. That's going to help people with disabilities. That's going to also help people who are really stressed and anxious because they're waiting in an emergency room or they're waiting to be seen by a doctor or get a vaccine. We can also give a lot of information in the process, right? Using a calm tone of voice, asking permission, providing warnings about transitions when we're providing treatment, when we're giving interactions, really clarifying the expectations for people. Visual supports are so helpful. I think sometimes we tend to think about pictures and videos either for kids or for people who don't use language, but really having visual aids is really helpful because it reduces the uncertainty and anxiety, and it gives us an opportunity to really reduce that cognitive load. If you see a stop sign, you know what that stop sign's asking you to do before you can read the letters. If you see a mask, a picture of a mask on a door, you know what the restaurant, the hospital, the office is asking of you before you read the actual text because pictures are supportive to our learning. Pictures and videos give people an opportunity to understand the expectations. And again, it reduces that cognitive load for us. One of the great things about technology is that we can give real, true pictures to prepare people for what things are going to look like. Gone are the days, if you remember, that we as providers were walking around carrying big binders full of laminated clip art graphics to try to connect with people about what they're going to see and what their needs are. We now have real, true depictions of what is it going to look like in the hospital. What are they going to do with a dental exam? How can we really show people and give information about what the environment's going to look like, what the interactions are going to entail, providing all those pictures and videos, but really doing it in a real supportive way that gives a realistic interpretation of the space and of the treatment itself. We can also be inclusive by just remembering how medication can affect processing, right? Medication can cause fatigue and lower people's ability to concentrate. Medication can impact short-term memory, people's ability to answer questions, to follow directives, to transition between spaces. We also see this with stress and anxiety. The skills that we typically have when we're calm and ready to learn may be unavailable to us when we're feeling stressed and anxious, and that's very typical of clinical settings for people to feel stressed and anxious, particularly for people with language and sensory needs who may already feel stressed and anxious as a baseline, even before entering clinical spaces. And the key is to really, again, make people feel welcome and that they belong and that they were really able to get their needs met in this settings. Some helpful specific ways to communicate. We can use short sentences. We can check for understanding. We can be really specific about what we need and what we're asking. Definitely allowing time for processing, time for response. Eye contact is not a prerequisite for understanding. Sometimes people's receptive language does not match their expressive language. Sometimes expressive language doesn't match their receptive language. So just being open to providing information in different ways that might be best to connect more person-centered for the person according to their language needs is helpful. Also thinking about avoiding leading questions and multiple choice questions. Sometimes we're telling people what we want to hear when we're asking them questions. How's your ear? Is your ear feeling better? Well, I hear you telling me that my ear should be feeling better, right? So kind of asking those leading questions, even though we want it to be a communication support for people, that we are able to really get the information that we need. We also can sometimes run into communication barriers with giving multiple choice questions unless we have a picture or a visual support, because from an auditory processing perspective, multiple choice questions can be difficult. I might ask you, do you want to go to the movies or the beach or the library? And you may say the library because it's the last thing you heard. You may say the movies because it's the first thing you heard, and you are stuck on that. You may hear the beach because that's your favorite, or you might say yes, not realizing that those are all different options and that you have to select only one of them. So from a language perspective, multiple choice can be difficult for people with their recall, with their ability to choose. So we want to include pictures, maybe showing people what the options are, asking them to point or pick just one of the things if that's something we need them to do. We also want to think about using pictures, drawing faces to help identify feelings. I'm sure we're all very familiar with our 1 to 10 pain scale, where people are in labor or in surgery or in distress, and we check in with their pain by asking them how they're feeling on a scale of 1 to 10. And most people will say 10. because that's when we're asking them, right? We're not often asking people about their pain when they're having lunch or watching TV or on a date or at the beach. We're often asking people on a scale from 1 to 10, how is your pain? And then we get those responses, and it's hard for people to gauge or judge any changes in that. So, if we're going to use pictures, if we're going to use videos, it's so helpful to have those meaningful, concrete images to really connect people to real experiences. So we're able to use these tools in a way that's going to be relatable and accessible for people. So on your screen, you see there's some emojis that we can indicate and help people understand what their feelings are. Feeling happy, feeling sad, mad, fearful, calm. Again, with technology and with apps on our phone and smart devices, it's so easy and accessible for us to do this now for folks. And we want to really have, again, those meaningful and concrete images. These emojis may not connect with people. People will not be able to understand maybe the nuance between these small changes in these spaces. I'm sure you've also seen feelings thermometers and color-coded ways of looking at our feelings. If we're green, we're good. If we're orange, we're not. If we're red, we're bad. And looking at blue for fatigue or illness. However, we're using these images and pictures and colors to help people understand their feelings and to communicate more positively, we want to be able to give concrete examples that people are going to understand. So on your screen, you see some versions of weather. And typically we think it's a sunny day. This is great. And then if it's a stormy day with a hurricane or a tornado or this rain cloud, that's not so great. But it might be hard for people to understand the difference and to really be able to work through this nuance in between. So it's very helpful for us to have specific ways for people to identify their emotions that connect to things that are important to them. Let me walk you through this example for someone that we might be supporting to understand and label their emotions. We see this storm cloud here, and for this person, the worst thing that could happen, the scariest thing to make them feel unsafe in this setting is that doctor, that nurse, looks just like my abuser. That person who's supposed to help me looks like someone who used to hurt me. So we're able to really operationalize and label that. On the other side, we say, what is the best, happiest thing that could happen? I'm at the lake or the park or a ball game with John, and I trust him and I feel safe with him, and I'm in my favorite spot with my favorite person. That would be the best thing to happen. Watching TV or a movie on a Friday night, not too bad. It's not the ball game, but I'm doing okay. If I lost my phone or tablet on the bus, I would feel sad. I might cry. I can't talk to my family. It doesn't have my anxiety app on there. I lost something that's expensive. I didn't do my homework and I can't get my email. That would be bad, but not as bad as if I ran out of my anxiety medication and I didn't have any refills, right? So we're starting to see certainly the value and the usefulness of pictures, of videos, of labels, of icons, but to make them meaningful for people, to practice with them when people are calm and ready to learn, so that when they're not calm and they are struggling, we do have these reference points to support people. We want to know if people are mad or sad or scared, or confused or tired or angry or happy. But we also want to support people in knowing how to get the help they need when they're feeling those ways. So using these concrete examples is really helpful. Other ways to just make more accessible messaging is to think of plain language. We tend to use acronyms, jargon, colloquialisms, idioms, sarcasm, that might not necessarily connect with people. So clear, plain language is a great way to make things accessible. Applying universal design, again, this is framework where we do the most for the most people. We make sure that we are providing as much support and resources as possible. It's not necessarily disability specific, but it will certainly help people if they have additional needs. Using different modes of messaging and communication, having things that are written, but using pictures and captions, having videos and technology. When we're including practices that are going to help everyone, we want to do our best to include the people that they're going to help. So, if we want to add accessibility to our communities, if we want to create spaces that are more accessible, we can engage with the community, have some co-design, think about what would be helpful as people come into these settings, test it with users, test it with people with different needs, create those local partnerships with our healthcare providers and our disability providers and people in the community and their families who use our services and come to our spaces to make sure that we are being person-centered, but also that things are tested and that they're working and that we're always improving to make them better. And tailoring the message. That's health messaging 101 is that people need to hear things in a way that's going to be meaningful to them. So whether that's in big picture messaging about public health or vaccines or health screening or mental health care and wellness, or it's specific treatment concerns about your medication, your symptoms, your treatment, your provider, just being able to be person-centered and accessible with the message that we're giving to people so they understand what they need to do to get their needs met. Some of us are clinicians, some of us are not. Some of us are family members or individuals. Most of us seek care from others in some way in the community. So we're all health communicators, even if we're not officially scientists or researchers or doctors or health providers. We all have the ability to just increase accessibility and inclusion across settings. Maybe we're chatting with people at a health fair or another local event. Maybe people are coming to our health department or coming to our website to learn about a vaccine appointment, to learn about a screening tool, to connect to another resource. We can be inclusive in our communication in that way. When we post on our social media accounts, even if we're not posting specifically about health information, remembering all those important pieces and social determinants that are tangential to health, transportation, community, housing, worship, recreation, hobbies, all the information, we want it to be understandable and simple and relatable for people. And again, having those partnerships. We're not going to know everything about everything. Events like this, opportunities to connect, to hear from our community providers and partners, gives us an opportunity to just be able to share that information more efficiently, in a clear way, just to continue to elevate settings to be more accessible. So as we leave into the next part of our day and into the next part of our work in community, it's really helpful to think about creating accessible, inclusive spaces through this lens of health equity. Where do disparities come from? Disparities come from preventable differences. How can we close those gaps to make sure that the services, the information, the experiences, the resources are available and accessible to people who have disability experiences in the community? Thinking about those barriers to access, certainly physical barriers, but also social barriers, funding barriers, other access barriers. We want to create a competent workforce. I've said it a couple times in this session. I'm sure you've heard it in other sessions and from your own experience. When we encounter other providers and professionals who don't understand the disability experience, that is a gap that we want to close. We want to give people information about how to help others. And they're not necessarily special needs or special programs or specific um, ways that we teach people, but just again, inclusion, accessibility, making modifications, using the things we know that work, but then adding in accommodation so they work for everyone, right? That's what accessibility means. And just really thinking about communication and literacy and messaging that is going to help people get information in big and small ways that's going to help them to get the help that they need. I want to point your direction to a couple of tools and resources. And then I'd love to hear some questions and discussions with the time we have. The Boggs Center on Disability and Human Development, the website is here. We have lots of great opportunities for publications that you can check out to support people with disabilities across the lifespan and services. NADD is the National Association for Dual Diagnosis for families and individuals, elevating wellness and mental health for people with intellectual and developmental disabilities. Check out the NAD for their tools and resources. Our colleagues at MHDD, which is the Mental Health Developmental Disability Training Center, created lessons in anxiety, depression, trauma assessment, other areas. They're very accessible. These lessons are for people receiving services and their families, people with lived experiences using services, also for DSPs, clinicians, teachers, providers, and they're also in multiple languages. The Link Center is a relationship between mental health services and disability services, nationally connecting people between these two systems to bridge those silos and fragmented service gaps. And this link has information on all the resources with trauma, anxiety, depression, mood disorders, things related to disability and mental health, and disability and mental health. And you'll see some New Jersey specific resources here for you. Our colleagues at Start Services have a program to elevate capacity in mental health and behavioral health for adults in New Jersey with IDD. I included the website there. And also want you to have these resources available as you support people and their families to connect to these other resources that are available in our state to get the supports that they need. So I hope that you're finding them to be useful for you as well. So thank you so much for your time and attention to this important conversation. I want to leave us with these kind of next steps on this slide here, but I'm very encouraged by you all being here, and I'm very happy to take any questions or hear your comments.
Thank you so much, Melissa. We're
I
gonna,
think
yeah, so I'm gonna turn it over to Ayeli, who's gonna moderate the question and answers.
Hi, Melissa. Thank you so much for your presentation. We have a question in the chat. How can providers assess whether their services are truly accessible and inclusive?
Yeah, I think that's a great question because in many ways it depends on the outcomes of the people using the services. So the short answer is we ask them. We ask people who use their services, are you getting what you need here? How can we make it easier for you to use this service? What else can we be doing to make a more safe, comfortable experience for you? So I think that's a good evaluation of practices that are inclusive. But I think we can start with some of the things that we've talked about here today, just to have a baseline where we're thinking about everyone. Inclusion means everyone, accessibility means everywhere. So if people are being left out, or prevented from being in places, what we're doing probably isn't working. So we start with this framework of best practice, and then we apply it specifically to the community that we're helping. I hope that helps.
Yeah, thank you. Any more questions?
I did also want to mention that even though the focus of our presentation has really been on clinical spaces, doctors' offices, community spaces, and other settings, these are things we can apply anywhere just to promote inclusion and accessibility. People with disabilities are everywhere. They're in the doctor and the hospital, but they're also in the pharmacy and the grocery store and the library and the classroom and the health fair. So a real interdisciplinary approach to these practices are making sure that the things that we are doing are really useful across settings as well.
So there are people thanking you in the chat. So just wanted to share that Shirley said thank you very much. And Bonnie said thank you, Melissa.
Yes, and thank you, Dr. Light, for being here with us. Thank you to everyone else for making time to be at this session. Really appreciate your interest in this topic.
Well, Melissa, I really like all the practical information that you've given us that we can at least at Nutley Family Service Bureau, we can start applying, some of what you've talked about, immediately. And it reinforces, just letting us know we're already doing a lot of the right things. But this is just extremely helpful as we think about making our services, more inclusive and accessible.
And
So
I think most people want to do that. If you go to
yeah,
an emergency room, if you're in a doctor's office, or if you encounter a health provider who's not familiar with the disability experience, people want to help you. They want to know how to do this. They want to make things better for people so that their care is more comfortable. So, I found that in good faith and with best practice, as we just need to spread this information in a way that it gets to people who can help others.
yes, absolutely. Absolutely. Is there anything else you would like to add or we can
I
wrap?
would just add that this is very doable, right? This is doable. These are practical things that we can do. You don't need to be an expert in disability to make things more inclusive for everyone in your community. If you're a health provider, you don't need a extra special needs training program. What we need to do is, again, figure out what is working and make it work for everyone. And thanks everyone for your time.
Thank you. Thank you so much.
Thanks for having me.